This is the anterior drawer test. It tests the stability of the anterior deltoid ligament and the ATF, stability of the talocrural and the distal tib-fib joint. So you do a horseshoe grip on the talus and onto the tibia, and you do a slow push posterior, checking for rotation, excess motion, or clunking.
Okay, so this is the ATF ligament stress test. So what we're going to want to do is we're going to take the ankle, put it into plantar flexion, and we're going to want to put it into inversion, just like that. And what we're looking for is any reproduction of pain and to test the integrity of the ATF ligament.
This is the posterior talar glide mobilization. We're going to place the hand on the horseshoe grip around the talus and then around the back of the tibia to stabilize. And now you're going to apply a posterior pressure to improve dorsiflexion to the talus.
This will be a first MTP extension mobilization, having the patient sitting in a long sit or even supine if they prefer. You will have the foot uncovered. You will stabilize with one hand near the head of the first metatarsal, using your other hand to mobilize the first phalange into extension while imparting an inferior glide to promote extension.
This is the MCL stress test, and what you're doing is checking the stability of the MCL ligament. You are going to secure the ankle and apply a medial pressure to the fibular head, and what you're looking for is any reproduction of pain or any increase in movement of the knee medially.
Okay, so this is the anterior drawer test, which is going to test the anterior cruciate ligament. So how we're going to do this is we're going to get the knee to 90 degrees of flexion. Okay, and we're going to take the hands and place it posteriorly around the tibia, and we're just going to pull it towards us. And we're looking for any reproduction of pain and to test the stability of the ACL.
This is the posterior tibiofemoral glide. What we're going to do is have the knee in flexion, and then you're going to place your stabilizing hand on the femur, and your mobilizing hand on the tibia close to the joint line. You're going to apply posterior pressure to the tibia in order to improve flexion.
Okay, this is the Faber Test, and it stands for hip flexion, abduction, external rotation, and is a provocative test used for the hip as well as the SI joint. So what you do is you place this foot on the ankle, you stabilize the opposite pelvic girdle, and you place a downward force on the knee. And what you're checking for is positive if you have pain reproduction in the hip or in the SI joint in the buttock.
Okay, so this is the Ober Test. So this is testing for tightness in the IT band. So how we're going to do this is we're going to bring the leg into abduction, into extension. We want the knee slightly flexed, and we want the whole leg externally rotated, and we're going to gently release the leg. And a positive test is shown by the leg staying in abduction. There you go. It's like when it gets up.
This is lateral distraction of the hip. You apply a belt around the proximal femur, and you're going to apply a hand on the knee to stabilize, and then apply a lateral distraction to the hip. This is used for pain and hypomobility.
This is a posterior to anterior mobilization of the thoracic spine. What you want to do is locate the spinous process of the vertebrae and use your pisiform to apply a posterior to anterior pressure. And you can move to the next vertebrae, applying that posterior to anterior pressure. Side-lying lumbar flexion mobilization. What you want to do is hook under the patient's arm. You want to locate the vertebra that you're going to be working with. You're going to apply a traction force to the vertebrae above and the vertebrae below. And then what you will do is use your body and the patient's pelvis to apply a side-lying mobilization.
And SI joint gap mobilization. You will locate the lateral iliac fossa of the pelvis while the other side of the pelvis is supported by the table. Once you find that area, you're going to use your forearm to provide a medial and anterior force. This force between the table and your forearm is going to cause a distraction force at the SI joint, looking for reliefs of SI pain. This is a sacral compression test, a test for SI joint compression irritability. Patient will be lying supine. You'll locate the iliac crest of their pelvis. Once you have that located, you'll take one hand on the inside of that iliac with the other in a cross pattern and provide an outward force causing compression at the SI joint, looking for reproduction of pain.
This is the cervical compression and distraction test. This is to get the green light from your patient before you work on their neck. So first you're going to do a distraction. You ask, is it better, worse, or the same? And then you can do a compression, better, worse, or the same.
The Spurling's test, testing for radicular pain. You want the patient to extend their head and side bend to the affected side. A positive test is the reproduction of pain.
This will be a cervical side glide mobilization. Once you have cleared the patient for manual therapy work on the neck, you will use one hand to support the head while you use the other to find the vertebrae you're working with. Once you've located the offending vertebrae, you're going to use a claw grip to place one finger on one transvertebrae and your thumb on the other. Once you have a good hold there, you'll just impart a lateral glide to one side or to the side that you're trying to promote the mobilization for.
I'm not going to do that because she said you can do lateral and you'll figure it out. Because if they're tight on one side, you're out.
Shoulder empty hand is test the supraspinatus tendon. So you bring the patient to about 90 degrees, shoulder abduction, internal rotation with slight resistance, and what you're looking for is any weakness or reproduction of pain.
This is the painful arc. It's a test for shoulder impingement. The patient will come into an abduction movement, and a positive result will be indicated by pain between 60 and 120 degrees.
This is the anterior apprehension test, you want to passively abduct the shoulder and then externally rotate. A positive test is if the patient has pain in the anterior aspect of the shoulder.
So this is the shoulder lateral distraction. Can be used for pain. So you just passively move the patient's arm into some abduction and internal rotation, and you can apply a sustained traction
Okay, so we're gonna do
or
posterior mobilization of the shoulder.
oscillations.
Okay, well, posterior mobilization to get the spinal humeral joint, so we want his.
So this will be a posterior mobilization of the shoulder. You'll take the upper extremity while supporting it between your axillary and your forearm at about 30 degrees of abduction in the scaption plane. You'll then use your other hand onto the anterior aspect of the shoulder, and you'll provide a anterior to posterior force for the
It's a
mobilization.
distraction, so I just wanted to say hold it for a few seconds. It's okay. As long as we got the motion, and then that one is for. That's just continuing.
The AC mobilization, you're going to stabilize the acromion and then grab onto the clavicle and move the clavicle into anterior and posterior glides, and this is going to help with AC mobility.
Alright, so this is the resisted testing for tennis elbow, and it tests the extensor carpi radialis brevis and the radialis longus. And what you're checking for is any weakness or reproduction of pain. So hold, don't let me move you, or hold, don't let me move you.
This is a resisted testing of golfer's elbow, testing the flexor muscles. You will have the patient go into wrist flexion, and you can test the flexors with resistance added.
Glide of the radial head of the proximal radial ulnar joint. First thing you want to do is locate the radial head. You can find about where you think that is at, and then pronate and supinate the arm to confirm it. Once you have located that radial head, you'll get a good grip onto that radius near the proximal position. While you supinate the forearm, you're going to provide a posterior glide to that joint, and as you pronate, an anterior glide. This mobilization will help restore pronation and supination to the forearm.
Humeral ulnar inferior mobilization, we're going to place the hand distal to the joint line, and they're going to apply an inferior glide while moving into flexion to improve flexion of the elbow.
Tinel Test. It is a test for the reproduction of carpal tunnel pain. You will apply a tapping pressure at the carpals and moving up to the forearm. A positive test will be reproduction of pain and in the median nerve. Phalen's test. It is a test of reproduction of carpal tunnel pain. You will have the patient bring their arms up and hyperflex them, pressing into the palms. A positive test would be reproduction of pain.
A posterior carpal mobilization. You want to have the patient place their hand in either neutral or a slight flexion. Demonstrate it from this side. Locate the carpal that you want to mobilize and apply a posterior force. Usually easier performed in this position.
MCP destruction, you want to stabilize at the second metacarpal and distract at the phalange, and this is going to help to improve joint nutrition and decrease pain.